welcome all the speakers, panelists, and the participants on behalf of KEMCA UK. The morning after, it's a very interesting title of this session. And that reminds me of a thriller mystery released in 1986, when Jane Fonda, who was the actress in that movie, wakes up in the morning and finds a very strange world around herself. And I think that's what we are exactly experiencing after COVID peak. There are some housekeeping rules before we start our talks of this session. Obviously, there is no caution about fire alarms, or there is no suggestions about toilets. But the housekeeping rule in this session, just to remind you that you can place your question through a chat. Our panelists will pick it up and will forward it to the panel members. And you need to fill up a feedback form so we can issue your CPD certificates. So we now proceed with our first talk. And as you know, it is very important that how COVID has affected the services in healthcare system. And cancer services are the most vulnerable ones. So therefore, the first talk is about how the cancer services were affected with COVID-19 pandemic. I would like to invite our consultant colleague, Dr. Mohammed Tufail, who is a consultant respiratory physician at Institute for Lung Health, University Hospital, Leicester. He's also acting as a cancer lead in lung cancer. And welcome, Tufail. I'm just going to unmute. Yes, you're sharing your slides. And so over to you now.
Thank you very much, Waqas and KEMCA UK. It is really a privilege to be the speaker for this session. And as a chair, KEMCA UK, I will really thank KEMU and KEMCANA from USA to have a collaboration with us. And so far, it has been an excellent sessions. And I'm sure you will enjoy the third session as well. So I will start with my talk, which is cancer services and COVID-19 pandemic. So patients with malignancy appear to be more susceptible to severe infection. And there is anecdotal evidence that mortality in cancer patients due to COVID-19 is much higher than the population which does not have cancer. And that is mainly due to immunosuppression, especially in hematological malignancies. And also in case of lung cancer, there is some sort of pulmonary compromises involved as well. And obviously, comorbidities should not be forgotten about this. And then for COVID-19, we did widespread lockdowns, curfews, border controls, and which led to reduction in presentations and also delayed referrals. For example, in April in the UK, there was a 60% reduction in referrals for cancers as compared to the same month in 2019. So patients are not presenting with cancer, and there is a backlog of these patients there. Obviously, this is not to say that cancer incidence has gone down. There is cancer still in the community, but they are not presenting. And the current projections indicate that COVID-19 related disruption of healthcare systems at all levels, whether it is cancer or not, will minimally last for 16 to 18 months, if not longer. And it also depends upon vaccine development, as you all know. And this has led to the oncology community to reconfigure the diagnostic and therapeutic pathways. Otherwise, there is no way around. And this is one of the examples from different organizations and societies throughout the world to prioritize management of cancer patient, or even rationing really. I mean, you can say here that from priority A to C, priority A is the patient who really are in need of our interventions. For example, patients have got quite aggressive form of leukemia, or have good brain metastases, or have good aggressive lymphoma, or they come with lung cancer, and the first presentation is superior vena cava obstruction or spinal cord compression. So these types of things were prioritized as priority A. But the other things, palliative indication with no significant survival benefit, routine cancer screening, and everything was stopped during the pandemic. And that was per se the right thing to do at that time, because all the healthcare services were focused to control this pandemic. And so this type of rationing was evident in each and every country in the world. And this is a guideline from ESMO, which says, for example, surgical oncology priorities for lung cancer. So my talk will be more oriented towards lung cancer, because I'm a consultant pulmonologist with an interest in lung cancer management. So you can see that ESMO produced guidelines for each and every tumor site. And for lung cancer, as far as surgery is concerned, they say continue to do surgery in all these indications where you can have survival benefit. But for other things, like just for diagnostic purpose, ground glass nodules, or anything which you think may be benign, don't do surgeries. For example, they stop doing surgeries for pneumothoraces and all those things, and for nodules. And so only if surgery is going to provide survival benefit. But during the peak of the pandemic, even we could not provide high priority services really, because many of our thoracic surgeons were redeployed. Many of the anesthetists in UK were redeployed to work in ITUs to manage patients who are intubated. So there were no anesthetists to run the theater list, for example. And this is one of the examples that lung cancer patients were dying when they were waiting for surgery for their lung cancer, which is curable. So that is the tip of the iceberg. So I will start with a case presentation. So this is one of our patients. He's a 67-year-old gentleman. He's very fit and well. His WHO performance status is 0. And he presents to us with the 6 weeks history of shortness of breath and cough. That was in February. And at that time, we did a chest X-ray followed by a CT scan. And as you can see, there is a tumor in the right upper lobe. It is staged as T2B and 2, which is multistation on PET-CT and M0. So we did an endobronchial ultrasound on this patient and proved it to be an adenocarcinoma with the high PD-L1 expression. So the case was discussed in our MDT or tumor board. It was decided to give him concurrent chemo and radiotherapy, and he received the first cycle of chemotherapy, cisplatin and vidralabin to start with, and then we were going to give him durvalumab immunotherapy. So what happened is he developed neutropenic sepsis after few days after the first cycle of chemotherapy, and after that he got COVID. No, this is a gentleman who used to walk 3-4 miles easily without getting short of breath, and no, he can't come out of his bed due to this COVID. And that's in his CT scan, and he's on 15 liters of oxygen. He has stayed in the hospital for 6 weeks, all the time on oxygen. We did everything. We gave him each and every treatment possible. Only thing we could do for him is that he survived this one, but he was sent home on 4 liters of oxygen. And we have seen him about 10 days ago, and this is his chest X-ray. You can see there are some persistent changes. He's still on oxygen. Will we be able to recommence treatment for his lung cancer? I'm really not sure. So you can see from this example that a patient with lung cancer develops COVID who was potentially radical treatment we were going to give, and no, this patient may not get any treatment at all for lung cancer. Sorry for this. So my next patient is another patient I have seen a couple of weeks ago. So this is a 61-year-old lady who has been having cough for last 4 months, and initially she thought it is all due to COVID. And this is her X-ray, and we did a CT scan, multiple lung metastases, and we have done CT guided biopsy, and this is leiomyosarcoma, I'm afraid. And I mean, there are delays in presentation we are seeing horrible presentation with lung cancer in the form of spinal cord compression and central tumors. And we have not done many stents for lung cancer in last 1 year whatsoever. We have done in last 1 month. So there is an upstaging of the cancer, and patients are presenting at a late stage, and this is all due to COVID. No, it is easy said than done that we have to balance the risks and benefits when you are investigating, especially for lung cancer. For example, one of the investigation involved in lung cancer is bronchoscopy, endobronchial ultrasound, and these are aerosol generating procedures. and the staff are at risk, and you have to provide them proper PPE, etc. And we have been advocating for many years. And when I develop my services and optimize our services, I used to present this data from T&M staging, that you can see that stage 1 of the lung cancer is divided further into A1, A2, and A3 according to size. And you can see if tumor is less than 1 centimeter, your survival rate at 5 years is 92%. But at the same time, your tumor is between 2 to 3 centimeter, your survival rate, 5-year survival rate drops to 77%. So millimeters do matters. If there are delays in intervention, in treatment, the patient's survival is worse. And that is true, and we have been saying that. But what about COVID? And these are the BTS guidelines for endobronchial ultrasound and bronchoscopy. And if any patient you think has good malignancy, and they are confirmed or suspected COVID-19 infection, you are not allowed to do bronchoscopy for 28 days. And you can imagine the havoc COVID-19 has created out of this. But I personally will be of the caution that you should not take each and every patient in same manner, and one size does not fit all. I mean, there may be some asymptomatic patient. Yes, they have got COVID positive PCR test, but do you really need to wait for 28 days? I think this should be rationalized according to one patient to the other. So there are challenges there. And this is our work. We work very hard, and we spend millions of pounds on our cancer pathway, where we decided to put up some screening, cook diagnostic pathway. As the patient has chest X-ray suspected of lung cancer, we took them directly for CT scan. So we really, our team worked very hard, and we presented this data at BTOG conference, and we developed optimal lung cancer pathway in Leicester. And we proved that if we intervene early, we get the patients early to us, we reduce the emergency presentations of lung cancer significantly. As you know, if patient is presenting as an emergency with any cancer, it is an advanced stage. Prognosis is poor. So what did we do in pre-COVID emergency in last year data? Our emergency presentation of lung cancer was 4% only. And since 1st of July, this is the preliminary data. And post-COVID emergency presentations have gone 5-fold up, but 22%. So this proves more and more patients are presenting at advanced stage. Now, another question I want to ask myself is, are cancer patients on cytotoxic chemotherapy or any other treatment, in fact, like immunotherapy or hormonal therapy, are at increased risk of mortality from COVID-19 disease compared with those not on active treatment? So the answer usually will be yes, they will be at high risk. And these are very two small studies from China came in February, and this study only involved 4 patients who had COVID positivity plus cancer, and 3 out of 4 died. So it came in the press, everyone stopped giving chemotherapy. And this is another study from China, looked at 105 patients, only 17 patients with cancer, any kind of cancer, developed COVID. And again, they proved that the mortality is high on the basis of these very small studies, in which there was 4 patients, and the other study there was 17 patients. Everyone stopped giving chemotherapy except in selected patients. So should we close our services if there is any resurgence of pandemic? That's our question. I think we have to be careful. No, UK has led again on this observational study. This is a consortium of 55 hospitals in the UK, and they have taken 800 patients. 800, I'm talking about 800 patients really, as compared to 4 patients and 17 patients in Chinese study. And they have proven, believe me, they have proven that if you give chemotherapy, hormonal therapy, whatever therapy you give, PCR positivity for cancer does not matter. Your mortality does not make any difference. The thing which makes more difference, the factors which do affect your mortality in cancer patients who are COVID positives, are age, cutoff age of about 60 years, if you are more than 60-year-old. If you've got hypertension, you have got cardiovascular comorbidities, diabetes. These are the things to look for. So again, I will say, don't treat each and every patient the same way. Take every patient according to their comorbidity, etc. And that has been proven in this study of 800 patients. So what should we do? What are my suggestions? I think we should implement strict protocol, social distancing, and universal masking for any patient suspected of cancer. Telemedicine is the way forward. Reduce the number of visits to hospital for all these patients. Provide shielding to them. There should be a balance between the desire to cure or treat our patients and the fear of losing them from infection. And this is a debatable thing, whether they are at risk of developing infection or not. And patients with symptoms of cancer should be encouraged to seek medical advice, please. I mean, they should not be sitting at home and presenting later on with spinal cord compression. And then innovations really like cytosponge tests for upper GI tumors like Barrett's esophagus and other things. And teledermatology is one of the excellent examples which has been implemented for skin cancers. And there's a pause on cancer research activities. I mean, as you know, in oncology world, research is the crux of the management of patients. If we have passed all the cancer research and we have concentrated on COVID research at the moment, it will affect us in next few decades, really. Because if you are not providing basic research, you are not developing new therapies, then our patients in future will suffer. The care of patients who have recovered after cancer treatment, they have got psychological problems, and they will be, will I get any recurrence? And when I get recurrence, will there be any COVID pandemic? Will I be ignored? These are the things you have to manage. And then palliative end of life care. No, you can't provide palliative and end of life care via telemedicine, I'm afraid. You have to be very kind and empathetic with these patients. I have heard very horrible stories of patients being discharged from the hospital with end of life care, and family was giving midazolam and morphine injections to administer themselves. And some of them don't know how to administer it. So we have to be kind and empathetic with these patients. And this is the education, communication, outreach. I think this is the time when tertiary care specialist oncologists have to work closely with our primary care physicians, improve our communication, educate them so that patients do present to us. So no, initially we told everyone, if you have got cough, stay at home, don't come out of the house. And no, we have to ask them, please come out. If in case you have got lung cancer, we can do something about it. So this is my last slide. I will end with an excellent editorial by Dr. Norman Shackles, who is a director of the US National Cancer Institute. He says in one of the very good editorial, clearly postponing procedures and deferring care as a result of the pandemic was prudent. It was important at one time, but the spread, duration, and future peaks of COVID-19 remain unclear. However, ignoring life-threatening non-COVID-19 conditions such as cancer for too long may turn one public health crisis into many others. Let's avoid that outcome. And so that will be the take-home message I would like to give from this talk. Thank you very much.
Thank you very much for a fantastic overview on the challenges we have gone through in cancer services in the past few months. I cannot disagree with you, being an oncologist, that screening and diagnostics are the important part in the cancer management, and it's a multimodality thing which we need to take into account. So now we move to the next talk. Definitely psychological effects are very important and we cannot ignore them. So we need to know from one of our speaker, Dr. Afzal Javed, who is Honorary Associate Professor at University of Warwick. He's also Chairman Pakistan Psychiatry Research Center, and he's President-elect World Psychiatry Association. I welcome Dr. Javed, and you can start sharing your slides.
Bismillah ar-Rahman ar-Rahim. I hope, Waqas, you can hear me.
Yeah, we can hear you. You can start the slideshow, please.
Okay.
Thank you. So over to you.
Well, thank you very much, Dr. Waqas, for your kind introduction. And I'm really grateful to KEMCA UK and the King Edward Medical College University, as well as our colleagues from US for organizing their help and assistance for making this seminar a real success. And I think this is a good beginning that all these three organizations hopefully will continue having similar educational and academic events in the future. I'm also glad that, especially during our first session, there was a mention of mental health, psychological effects, and more importantly, having some awareness that pandemic like COVID-19 can also be linked and can also be associated with a number of psychological and mental health problems. So during the next 15 minutes, I will try to address the mental health challenges that we are facing and experiencing during this particular pandemic. And I'll try to cover that what are the mental health needs during this period, what are the impacts on general population, mentally ill, and the health workers, with a special reference to their well-being and psychological coping. And then I'll try to speak briefly that what are the interventions and what are the options that we can opt at this moment, especially for our health workers who are facing a lot of stress and difficulties in coping with their hard work. I won't go into the details because this has been explained in a detailed way that this pandemic is now spreading across all the globe, and there is hardly any country which has been spared from this particular pandemic. And unfortunately, like many other pandemics that usually were linked to the morbidity and mortality, this particular COVID-19 is also linked to a number of other factors that includes financial stability, employments, coping, isolation, and difficulties in terms of communication with our nearest and the dearest ones. And we have heard a number of presentations emphasizing the importance of physical health impacts that are associated with this particular COVID-19. But when we talk about the mental disorders, we can always generalize a bit that vulnerability and predisposition for mental health problems is generally linked to poverty, unemployment, stresses, insecurities, domestic violence, social isolation, and reduced access to health care. So if we want to generalize these precipitating or perpetuating factors, it looks very clearly that this particular pandemic is very prone in terms of increasing the mental health problems. So what are the mental health needs that needs our clinicians and our colleagues' attention with the reference to COVID-19? But before I go for that, I just want to emphasize about the importance of mental health and mental disorders. This is one of the type of disorders that has got a high prevalence all over the globe. And it is generally estimated that at least 20 to 25% of global disease burdens are due to these psychological disturbances. Royal College of Psychiatrists, for example, highlighted this by saying 1 in 4, that when you look at the general population, you will always find that 20 to 25% of the population will be facing some sort of psychological problems. And then it is not only the prevalence rate that is high, the association of mental disorders can also have a number of other impacts like high rates of health risk behavior, for example, smoking, drinking, physical morbidity and comorbidities. I mean, you will be amazed to know that almost when we look at some disorders of mental health types, there is an increased mortality and morbidity as compared to the general population. And then the reduced expectancy of life. It is generally said that, for example, in schizophrenia, they die around 8 to 10 years earlier than their counterparts in the general population. And of course, mental health problems increase other social consequences on education, employment, interaction, stigma, and crime. So when it comes to COVID-19, we really find that this is not only a threat to physical health, but it has really long-lasting effects on mental health and psychological coping. And during a crisis, we always know that there is fear, sadness, anxiety, and apprehension. But especially in the current crisis, people may be fearful about becoming ill and dying, losing livelihoods, loved ones, and being socially excluded. And this is true for all those who test positive or who are waiting for their test results. And this is the anxiety that is actually leading to physical discomfort, separation from loved ones, isolation, and possibly increased stigma. We are at this moment undergoing and undertaking a number of population-based studies looking at the impact of COVID-19 in terms of psychological coping and psychological functioning. But up till now, some of the reports that are available in the literature that clearly shows that if you look at the population approach, you will find that the impact in terms of mental functioning is quite severe. There is high levels of stress, anxiety, depression, which can vary from moderate to severe in intensity. And then this concerns about isolation, concerns developing some mental health problems, social distancing, negative feelings, and of course, the practical issues related to finances and employment just add to the total picture, which obviously comes up as increased risk of depression and lower health-related quality of life. So what are the main challenges that we are looking within the mental health perspectives? I will just concentrate on three major challenges, and these are global challenges, and no culture, no country, and no society is immune to this. The first one, to prevent associated, anticipated increased mental disorders and reduced mental well-being across the populations. The second challenge is to protect people who are suffering from mental disorders from COVID-19 and associated impacts given their increased vulnerability. And the third very important challenge is to provide appropriate interventions to our frontline staff and carers looking after the patients with COVID-19. And then another challenge is the interface of mental health and COVID-19. There is evidence, and it is coming up with more and more studies, that this pandemic has resulted in a surge of patients with first episode of psychiatric disorders or psychiatric difficulties. And in addition to that, there is an increased relapse rate of patients with pre-existing psychiatric diagnoses. And patients who have to be compliant to the treatment, unfortunately, the isolation, the social distancing, lack of contact with their family physicians, carers, or the health services, that again increase to another complication of non-compliance, non-adherence, which certainly results in further relapses. And then managing and monitoring medication induced adverse effects if you are not in contact with your healthcare workers, or if you are having less contact with those who can monitor you or who can help you. And then another thing which has been highlighted by many of our esteemed speakers, that people with mental disorders are at an additional risk if they are suffering from COVID or high risk of COVID-19 infection and mortality. And as I said earlier, that the reduced life expectancy in many of our patients ranges from 7 to 25 years. And of course, other associated socioeconomic effects not only increase the problems, but also make these problems more severe and more difficult to manage. So the next challenge is managing mentally ill who suffer or who are going to suffer from COVID-19. And here, the interface of psychiatry and this particular COVID-19 is relevant for both positive and negative cases. This particular pandemic has brought new challenges for the management of psychiatric patient and administration of psychiatric treatment, especially during the lockdown. And the current literature shows that patients with pre-existing psychiatric illness may be reluctant to follow the precautions laid down due to their lack of insight. So it's a sort of a double edge that this lack of insight is increasing their mental health problems and then also affecting the COVID-19 precautions. And then again, it may be a sort of highly difficult, especially in low resource countries, to manage such patients in medical intensive care units where the staff are ill-equipped to handle psychiatric emergencies. So this is a sort of another difficult issue that we are facing and we are being reported. And one thing more, the drug-drug interaction, there has been a number of reports that show that the drugs that are used for the treatment of COVID-19 that may have some drug interactions with psychiatric medications. And some of the emergent psychiatric symptoms and side effects are of neuropsychiatric origin, which could actually create more difficulties in the adherence for psychiatric treatment. Healthcare workers, as I said, this is another major challenge. And we know that if we look at during the time of stress, during the time of a situation like any pandemic, the stress among healthcare workers in routine care is considered to result and lead to severe distress, burnout, and psychosomatic problems. And if we are not taking care of the healthcare workers, that will have again a direct and indirect effect on our population. And there are some reports coming up about the healthcare professionals that they are having higher rate of stress, anxiety, depression, burnout, and PTSD symptoms that could be difficult to manage and difficult to treat. And that certainly is another problem. So, yeah, managing mental health problems with COVID-19, I think dealing with this triple global mental health challenge, we need to have strategies to prevent an associated increase, to protect people with the mental disorders from COVID-19, and to provide appropriate public mental health interventions to health professionals. And mental health is being promoted to be conceived and practiced as public mental health. And I think promotion, prevention, and treatment are the salient features for that. And this is my last slide, that from the public mental health perspective, and these principles can certainly be very helpful for treating and managing mentally ill by promoting this particular concept and slogans: staying well, living well, working well, and aging well. And that really fits into very much into any pandemics like current one or any other situation where we may be having similar impacts, both physical and psychological. Thank you very much, Dr. Waqas, and I'm really grateful to KEMCA UK for this kind invitation.
Thank you very much, Dr. Afzal Javed. It was a fantastic talk. And I like your last slide having all the slogans, and I agree with them. We definitely would have some burning questions at the end, and we will allow the panelists to manage it. So our next talk is about the surgical services and how they were affected by COVID-19. I would like to invite Professor Amjad Pervez Cheema, who is a consultant laparoscopic surgeon at Poole General Hospital and Director European Academy of Robotic and Colorectal Surgery. He has recently been appointed as a professor of robotic surgery at University of Heidelberg, Germany, and I would like to invite him to start sharing his slides. Yes, I can see your slides, Professor Cheema. So over to you. Thank you.
All right. Can you hear me, everybody?
Yes.
Right. Well, thank you very much once again for the kind invitation and taking time on Sunday afternoon. I'm sure I speak on behalf of many surgeons, if there are any, listening to this, that one of the things this pandemic have proved is that, this myth of surgeon believing that they are God is completely broken. We are just like any other healthcare professional who are pretty much out of work for the first 6 weeks of this pandemic. So this is an interesting topic for me to sort of spend next 15 minutes on. This is really for the information of people who sort of couldn't recognize Poole. Poole, part of England. Poole is where this Bournemouth big city is. Poole is just next to it. I live around here and travel down every 1 week, every month. So I'm very distinguished in a way that I have opportunity now to share my workplace between UK and Europe. And that has given me a kind of a very nice window setting to look into practices or healthcare practices during this pandemic across Europe and have an objective view of things. I spend 2 weeks a month in this nice place. This is in Lisbon, Portugal. I haven't been able to travel to this place since March 14th, as you would expect. But we hope that the cancer services will resume there in September, and then we'll be able to travel. So people who are interested in coming to nice places and seeing some nice surgery, they're always welcome. So this was really a scale of problem. It is an unknown entity. And although we kept sort of saying that we were following science, we actually had no clue where the science is going to lead us. So we were sort of making it as we go along kind of philosophy to begin with, to be honest. UK and Europe had a slight advantage at the expense of Italian nation, that we saw the pattern, what happened in Italy. And then, as we know, in this country, that imperial model sort of came up with a much bigger frightening number of where this whole pandemic could lead to. And then most guidelines at that time were based on potential predictions. And then further logical thinking come along. So, this is an important thing to remember when we talk about how the services have been impacted at the beginning, but most importantly, with the fear of second wave coming in and misdiagnosis, delayed diagnosis, cancer care being sort of put at the back burner, as Tufail mentioned. These haven't, they would come out of the woodworks, and unless we have a capacity to, we have a problem. This is really interesting for me, preparing this talk and talking about my academic colleagues around the world. If you look at the publication that have come through, and this is a really nice paper written by Nader Francis. When I say paper, it's pretty much correspondence with BJS, because most things published are personal views. And they looked at a really couple of months of what has been published so far in the literature, nearly 2,500 studies. And have a look at this. The most prevalent publications were self-reported commentaries, experience based on recommendation, and correspondence or letter to editors. So very few really backed by very high level of evidence. So this is really they're sort of saying that whilst these guideline recommendations were offered in a very best of interest, but they really lack the best clinical practice evidence. And we have to remember this in the context of general surgery as I sort of go along in my presentation. This is another sort of paper. So why COVID is a problem in surgery? So everybody asks about this. The COVID is a problem in surgery because the impact it has in perioperative outcome to these patients. This is one of the first few papers that came out looking at COVID positive patient following their elective or emergency operation. This is published in Lancet, a reasonably good journal as you would expect. Hang on, I would just see if I can move this forward. I think I have to sort of put it back on. Are you able to still hear me?
Yes, we can hear you. And
there was a difficulty in trying to move the slide. Okay, hang on, maybe I need to do it here. Okay, this should work. All right. So it is moving now. So if you look at all this, this is the bigger problem, which I've just highlighted in yellow column, that if you happen to be COVID positive in your post-operative period, This is not a huge data, but still a decent number, like 1,000 cases, really good number. 30 days is about 24%. That's quite high if you are a patient who's sort of come in for potentially an elective operation, given there were some emergencies as well. So this is the price tag attached to these patients who are coming into hospital, risk of becoming positive in the post-op setting. So when the whole thing kick-started, this was really the strategy most of the surgical clinics around the world had. Emergency took precedence as expected. So emergency workflow became more important. I haven't done on-calls for surgery for the last 6 years. So because I only do elective operating, I had to sort of leave my comfortable role and then become available to cover emergencies. And then there was an issue of capacity management, which means that as we were expecting a big wave coming in based on Italian model and imperial model, most of our operating theaters were converted into potential ventilated beds, and the recovery or the anesthetic rooms were potentially given away as well. So we did no elective work within NHS hospital where I work between 14th September to nearly 14th March to 14th April, nearly 4 weeks. We didn't do any elective work for cancer services, only emergencies. Then the focus really was to retain staff by making sure they don't fall ill, and then redeploying them. And in some of the NHS trusts, this happened. Thankfully, it didn't happen in our trust because I wouldn't have a clue what noise the ventilator is making and which button to press. But in some of the NHS hospitals, surgeons were asked to take a crash course and to provide services. This is one of our own correspondence that we sort of sent to BJS, looking at colorectal cancer services and impact it had, the COVID impact on colorectal services within this. Remember, this is not evidence-based. This is based around potentially a personal experience and giving recommendation based on this. This paper sort of suggested, or this correspondence suggested, that we should just cut ourselves to providing emergency dissection work, consider stenting if you can stent the obstructed tumors rather than operating on them, and put in the basket or put on hold very early or very advanced, locally advanced tumor, because very early would not obstruct, would not come to any harm while waiting, while locally advanced tumor often required intensive care bed because there were multi-visceral dissections and multi-specialty involvement. So they were put on hold as well. Most rectal cancer were considered for a short course radiation and wait watch policy and see them afterward when the pandemic is over. This is the cost, which I call a hidden cost of COVID-19 on surgical services. It is anticipated that within UK, in my own specialty, which is a colorectal cancer, nearly 200,000 patients have missed their diagnostic test with suspected cancer symptoms because of this backlog, and it would have a huge repercussion. This is a predictive model looking across a number of countries, what impact it is likely to have. I'm sorry for a lot of writing on the slide, but you could almost sort of make out that even within different specialties, they are anticipating there is about 36 to 40% delay or cancellation of elective activities because of the pandemic challenges that is faced by surgical community. The same is true for benign cases as well, even worse in benign cases, nearly 80-81%, because there is no urgency. So it has got a hidden cost, which we have to sort of take into the account. With pandemic hitting, this was one of the first things that came out of Royal College of Surgeons. They came out with recommendation saying that open surgery should be performed because minimally invasive surgery was considered to have a high risk of aerosol spread through diathermy smoke. But further as we went along, I showed you the initial slides of suggesting that this was all based on logical thinking and common sense decision making with a lack of any evidence. Most centers start to show that laparoscopy or robotic surgery was pretty safe even with this pandemic. This is our own data from pool, which is currently being awaiting publication. It's been accepted in BJS, where we looked at our practice in NHS hospital around 6 weeks period, between March and end of April. We looked at our practice. If you look at 128 cases in general surgery, who performed both lap, open and robotic, and performed for emergencies and elective work, you could see none of the patient or the hospital staff became COVID positive during putting this myth to rest that potentially this is not the case. Change all this, what was needed to this, the infrastructure, the testing for both patients and staff change as more testing became available with rapid turnaround time. It was easier to do this, and modification in surgical practice has to happen to demonstrate this. This is just one example of that. This is a theater layout before COVID time. You could see the same door in and out through an aesthetic room and scrub room and dirty room. With COVID coming in, they made this as a donning area where we used to come in the morning, get all dressed up. Patient would come through here. This is de-donning area or taking the stuff off and using the exit completely differently. So these are sort of some of the measures that were put into place. So how did the practice change? It changed with this, with elective practice. Patients were asked to self-isolate once they're given the date for surgery. They have to be symptom-free for 7 days. They would be asked to have a PCR test 48 hours before the surgery. And at the beginning, right at the beginning, we were doing CT scan of the chest. In some hospitals, they were doing x-rays, but we omitted this very quickly. So it was literally history taking, self-isolation, and PCR testing 48 hours pre-op before they were asked to come for their elective operation. There was some modification in our surgical practice, obviously negative pressure ventilator system within the operating theater. Minimum theater staff was required, only who were essentially required during the procedure. Full PPE, which is mask shielding, N95 mask based on your fit test, and double gloving. Dual consultant operating. This had an implication on training, and I'm sure some of you guys have already spoken about it, and they would talk more about it. And then within hospital, they split the hospital into a red and green zone where COVID patients were treated or where patients were COVID negative. This is just to give you an example, people who are pushing for open surgery, this is an old historical picture from 1970. And I'm really glad that COVID was not around at that time because, these all surgeons have come in Texas to watch a cardiothoracic surgeon show them the technique. So open surgery, although recommendations is safe, is not without problem. Things do change, thankfully. This picture reminds me that the risk of having a heart attack is directly proportional to the TV screen you have in your home. Now we do a robotic surgery. This is for my colleague who are non-surgeons to give them the idea of why this has a relevance to pandemic, because you are no more near the patient. You are sitting much further away after gas insufflation. To give you an idea, if it plays, yeah, it does. So this is a patient console. This is a patient cart. You insufflate the abdomen, bring the robot close, dock the machine. And then once the machine is docked, you really don't need to sit into the same room. You can sit in a completely different room as long as you have access to the sort of monitor, as it were, to see. So you could see as the surgery is being done, the surgeon is sitting much more remotely, further away from all this. And that's why you don't need to wear a mask in this case, for example. So again, this is relevant as well because you could see these two similar operations done one in pre-COVID time, one in post-COVID time. One is done in Karachi, other one is done in one of the European centers, a demonstration case. The anatomy, the procedure, the technique doesn't have to change. The way that we work with our patients and the way we perform surgeries, becomes slightly modified. The anatomy doesn't change. Again, this is relevant now in this time. We don't have to be in the same room. This is a remote preceptorship being done. But that's okay. You could just take them where they come. So the surgeon is based in Athens. You're sitting in London, navigating them. This is a new set of minimally invasive surgery, which is being practiced now with 5G technology. You can operate sort of 60 to 80 miles away. So all these new things would have huge implication on how we want to practice surgery in post-pandemic area in the countries which are able to have these resources. So in conclusion, I would like to say that this is a changing landscape and it's a continual learning process for all of us. To have a position statement that doesn't change or which is rigid is not a sustainable behavior, I think. We have to adapt our behavior and we would succeed. After all, we have succeeded 200,000 years of evolution, and we are likely to go through this. I'm pretty sure of that. Increasing the testing capacity and shorter return of test time obviously is a key. Infrastructure modification need to happen. Key really is to protect your patients and surgical staff to deliver these services, and consider hidden costs, which have been highlighted before as well. I'll finish off by sharing this little line, which I genuinely believe is true. Only change is eternal, perpetual, and immortal. I'm really grateful for the kind opportunity. Thank you very much.
Thank you very much, Professor Cheema, for a fantastic overview on the challenges faced by surgical side and some conveying pictures and interesting local figures. So now we move on to the next talk. And I would like to invite Professor Mobeen Rathore, who is a professor of pediatrics, University of Florida, USA. Though the incidence was relatively low in younger population, but we would like to know how COVID-19 impacted the services in pediatrics. Thank you. Yes, you are sharing your slides, Professor.
Yes, give me a second here. Trying to get to the appropriate slide here, if I can move this thing.
Had a slideshow, yes.
Okay, I'm not doing so well here. All right, there you go.
I think you still need to.
All right, can you guys see it now?
No, we can't see your slides, I'm afraid.
Okay, hold on a second, then. Are you able to see them now?
I think they are coming up now. And if you now start the slideshow, I think when they disappear again, I'm afraid.
Oh, hold on a second. I've started the slideshow, and when the slideshow starts, it looks like it disappears, but I'm going to try one more time.
Just, yeah.
Can you see it now?
You can see your slides, and if you just go to slideshow.
Are you able to see them now?
We can see your slideshow, yes.
How about now?
Yes, they're fine.
All right.
You can
Thank
start.
you. So thank you very much, everyone. Assalamu alaikum. It's a pleasure to be talking to you. Thank you for the organizers for doing such a terrific job. I'm going to take a slightly different tack than the other speakers. Our systems are so different, the UK and the United States. I will tell you the two main things that have changed for pediatric services in the United States. One, we have gone in a big way on virtual visits. We are doing a lot of telehealth. A lot of the children are being seen by virtual visits. That was during the lockdown time when by executive order, we were not allowed to provide any elective services, although many of us believe providing immunization to children is not an elective service, but an essential service. And then what happened with that is that the immunization rates have fallen drastically for children. And one of the big ones that we are really concerned about is measles, which, for example, in Jacksonville, the immunization rates are below 70%. We are trying to catch up. We are trying to do a lot of community activities to make sure that we are able to address this issue of immunizations. But I'm going to basically talk to you guys about COVID-19 in children, and I will go, when I reach a particular topic that has some implications with the services that we provide, I will address that. Okay, well, I want to start with this slide because those of us who take care of children, we know that we have been taking care of coronavirus for a long time. There are 4 coronaviruses that cause infection every year, and every 2 to 4 years there may be an outbreak of one or more of the coronaviruses, and we know that this disease is much more severe in neonates and although more common in children than adults. So we have been familiar with the coronavirus, and some of those things that we saw with other coronaviruses also pertain to what we see in COVID-19. Now, this is, I think, probably the most important slide I'm going to leave you with. If there's nothing else you remember this. 6 E's of pandemic management. There are no experts on this. This infection is only 7 months old, 7.5 months old. So anybody who claims that they are an expert on it, be very suspicious of them. Then also, everybody's an expert. If you have a WhatsApp account or a social media account, you are an expert. You know everything about it, and you can manage it, and you know what the problem is. I think you should focus on people who have experience in pandemics and outbreaks and epidemics. They can use their information of epidemiology, infectious diseases, and then they can extrapolate from other infectious diseases a best guess on how the pandemic should be managed. So remember the 6 E's of pandemic management when you're talking about coronavirus. We all know, I'm going to quickly say the risk stratification. I'm not going to read through this, but we know that the risk of, first of all, let me get rid of one misconception. Kids are as likely to get the infection as adults are. It just so happens kids don't get as sick as adults. This is an equal opportunity virus. It does not care what your age, your race, your ethnicity, your gender is. It's going to infect you if it gets the opportunity. But children do have mild illnesses. What we don't know is many of the things about can the infection be transmitted from pregnant women to the newborns. We do know that there is no evidence of this transmission of this virus through breast milk. And we also now know that infection can be more severe in infants and neonates. This is, I think this is also an important slide. I'm sure this is similar sort of thing you have also seen in the UK, where we have seen that the racial, ethnic, and socioeconomic association of SARS-CoV infection, SARS-CoV-2 infection. And this slide just shows you the differences if a race ethnicity has on the infection or the severity of infection even. With using non-Hispanic whites as their reference, you can see that the African-American blacks in the United States have almost 3.5 times higher risk of getting this infection. Hispanics are more than 6 times, and other races almost twice. But this is also associated with your median family income. And as you can see, compared to the reference, which is the highest quartile of income, all of the others have at least 2 or almost 3 times the odds ratio of getting the infection. I suspect this is not much different than what you see in the UK and other parts of the world. It is my understanding that Afro-Caribbeans in the United Kingdom have had a higher risk of infection than other populations. So if you want to look at other ways, in this particular study, that 1,000 children tested for SARS-CoV-2 infection, 20.7%, almost 21% were positive, and you can see how they were distributed. 30% were African Americans, and 46% were Hispanics. By quartile, if you look at the first quartile, it was 37.7% compared to the fourth quartile, which is the most affluent. It was only 8.7%. So there's a huge difference in socioeconomic and race ethnicity factors. And this we have seen, and this also goes back to access to services and disparity in care in healthcare that already existed. Now, unfortunately, the disparity in healthcare in the United States existed much before the pandemic started, and we were all aware of it. The pandemic just made this more vivid, and the ugly nature of the disparities just showed in terms of the increased infection in the populations who have significant barriers to healthcare and got serious infections. Before I go to the slides which talk about some of the signs and symptom infections in children. I wanted to share this slide with you, and I'm not going to review you can see it on your screen. The important thing I want to mention is that we as pediatricians are going to face in the coming months a lot of children who are going to have colds. We may even see influenza. I remember in many parts of the United States, I'm in Florida, we still have a very high prevalence of this infection in Florida. Our schools are opening. Some schools are opening Monday. Over the next couple of weeks, most of the schools in Florida are going to be opening up. And we are going to see a lot of children who are going to have other infections. It is going to become extremely, extremely difficult for pediatricians to differentiate between what is influenza and what is COVID-19. So it's a challenge that we will have to, unless we get some rapid point of care testing, it's going to be a huge challenge for pediatricians in their private practices, where they'll have to determine if a child can go back to school or not, especially if the school is going to ask the pediatrician to attest that the child does not have COVID-19. So we are very concerned that this is going to have a huge impact on practice. So here's I'll use a couple of slides to show you some studies. This is a study that was published in Pediatric Infectious Disease Journal, and it was a review of 11 studies. There are 333 children, 83% had a positive contact, mostly with family members. So just as we see in some of the other infections as TB and others, it looks like the index case may have been an adult family member. The incubation period in this study was anywhere from 2 to 25 days. The mean was 7 days, which is very well accepted by other adult studies also. They were able to isolate from nasopharyngeal secretions for up to 22 days and for stools up to 30 days. These were done by PCR, so isolation does not equate, or detection by PCR does not equate contagiousness. We won't have time to talk about that today, but just keep that in mind. It is also interesting that in children, 79% had co-infections, either mycoplasma and influenza, and that's what I think is going to be a huge challenge for us during the upcoming months, winter months, where other infections are going to be playing a role also. Not unexpectedly, 35% of the children were asymptomatic. Most common symptoms were cough, fever, and pharyngitis. Again, you can imagine those of us who take care of children, that's a very common presentation of many children during the respiratory viral season in the winter. 3% of these children were admitted to the intensive care unit. So they were either asymptomatic or had mild symptoms. Lab test parameters were only minimally altered. Radiologic findings were non-specific, unilateral, bilateral infiltrates, ground glass opacities, or consolidations, nothing that we could say is pathogenomic for COVID-19. This is another study. There is a European Journal of Pediatrics, which was all European patients, 7,000, almost 7,500 children, a little more than half were males. Mean age was 7.6 years. By the way, this mean age of 7 years is consistent through many, many, many studies. Again, mainly had mild symptoms, 42.5%. Some had moderate symptoms. Again, about 2% admitted to the PICU. The previous slide you saw it was 3%. So a certain number of kids will get very severely and get admitted to the pediatric intensive care units. Newborns are more likely to be severely ill, and in this case, 12%. And dyspnea was the most common symptom in the newborns. The other most common symptoms are fever, which is present in more than half of the patients, and cough, which was present in almost half. Now, as you can see, that half of these kids did not even have fever. So fever, which we take as in many studies, actually is the most common thing. In some studies, 100% of the patients had fever. They may actually be due to the fact that they were only including people with fever. Lab findings were once again often unremarkable. CT chest was done in 73.9% and was reported abnormal in 32.7% of the people. The overall estimate of mortality was less than 1%. Again, that's very consistent in pediatric studies. Here's the study for COVID-19 in children. Two of the studies, one was published in Pediatrics, other in New England Journal of Medicine. These two studies were the first studies that looked at these kids. Almost, as you can see, there are almost 3,500 children. And you can see, as I said, 7 years was the median age. And I think you can, again, predominance of males. And in The PEDS study, 94% of the children were asymptomatic or moderate, whereas the New England Journal of Medicine study it was 35%. Only less than 1% were critical in the New England Journal of Medicine, and there was no death. In the pediatric study, 1 death. And you can see at the bottom of the asterisks, the children less than 1 year of age were more likely to be critically ill than the older children. Some factors that need to be remembered: the incubation period is 4 to 6 weeks. For influenza, it's 1 to 2 weeks. I mean, 4 to 6 days. And I don't have time to show you this, but really, it's just before you get symptomatic during the incubation period that you have the highest contagiousness. The doubling time is 6 days. The COVID R0 is 2.5. For influenza, it's 1.3, so it's much more contagious. The related serial interval, there is a mean time it takes for an infected person to pass the infection to others, is 4.5 to 7.5 days. Again, incubation period is about 10 days. Infectious period is about 10 days after incubation period, meaning by day 14, most people are not contagious, and by day 21, almost no one is. Distance of spread is 6 feet. Other factors may play a role. I don't have time to go into that detail either. This virus can survive on surfaces for 2 to 3 days. This is a little controversial, but that's accepted. And it can suspend in air up to 3 hours, which is a problem because the person who's infected may be gone and may still be suspended in the air. And there are other factors that may play a role that may make the virus suspend longer. The case fatality rate still stays low. I'm going to skip this slide because I think most of have discussed this. So I want to talk a little bit about tests. There are several tests available because of the short time, 15 minutes for the presentation. I'm not able to go over that. The gold standard remains PCR. Now, it used to be in most other infections, we always use culture, but it's hard to culture this virus. The gold standard is the PCR. There are other studies. There's the NAT test. There is the antigen test, and of course the antibody test. I just present this, the antibody test. First of all, the antigen test, many people may be trying to use that in their offices, the point of care test. Antigen test is helpful if it's positive. If it's negative, it must be confirmed by PCR. The antibody test really, in my opinion, has no role in acute diagnosis of COVID-19 infection. It is a good tool for epidemiologic studies. It has a role in MISC. I'll have a couple of slides on MISC. I won't have time to go over all of them. But the bottom line is, if the PCR is positive, doesn't matter what the antibody says. And unfortunately, even though the antibodies are not that good, but if the IgM is positive, you have to assume that the patient is acutely infected and take appropriate action. We are not offering antibody tests in our health system. Mother-to-child transmission, there was one study report from China. It was a little controversial. It was only based on immunological evidence. Subsequent to that, there have been many studies. The last one was just published in Lancet of 120 mothers who were positive. None of those children, infants, newborns were infected. The test was PCR, and there are several points. It was probably the best study. JAMA had a study which had 3 of 33 children were positive. They again did PCR for nasopharyngeal and anal swabs, but there was some concern that some of the tests may have been done too soon. Then again, there were other studies that were published. They were basically case reports. So I think so far the conventional wisdom is, as conventional it could be for the last 7 months, that the perinatal transmission of this infection is extremely rare, if at all. So I think that's something we all can take some solace in. What do we do when newborn is delivered to a COVID-19 mother? Again, very limited data from maternal-child transmission of the virus. We limit the number of caregivers in the delivery room. We also do not allow anybody else other than the mother or the father to visit the baby in the nursery or the newborn or the NICU. And they, of course, have to have not a COVID-19 infection or be under investigation or any other risk factors. If the mother is COVID-19 or under investigation, we educate the parents and we separate the baby from the mother in the delivery room. This is a little controversial, I know that, but that's what our practice is. A mother could view a baby in the ice from a distance, bathe the baby as soon as possible. There are many places in the United States where they do not separate the mother from the baby. No evidence of presence of virus in the breast milk. I already suggested that to you. and like other things, this may change, so we need to keep our eyes open for that. We do not do testing on the newborns automatically unless they develop illness consistent with COVID-19 or their PUI. Some are recommending, as I said, co-locating the mother and baby.
Sorry, Professor Rathore, it's a second time check, please. Thank you.
Okay, I'm going to call this. There are no studies for treatment. We are using remdesivir. It is approved under Emergency Utilization Authority. There are no pediatric studies that are ongoing. Dexamethasone we are using. There's no vaccine. I'm going to hydrochloroquine. Other of these drugs, none of them are really proven. There are some options for ambulatory patients. Again, these studies are happening. We are participating in some of these studies, but currently there are no options. I just wanted to show you this slide. Vaccine is our best hope. There are two vaccines, the Oxford vaccine and the Moderna, that are in phase 3 trial. Some other Novavax is going to be coming on soon. We are participating in some of the vaccine trials. Vaccine, as I said, is our best hope. I will just give you one caution. I think it's extremely important that we don't get overzealous about it. We use the vaccine if it is safe. We need an effective vaccine. I'm willing to personally, and many people are willing to accept a vaccine that is 50% effective. But I don't think so many of us would be willing to accept a vaccine that is 50% safe. I think the reason is we have spent our lives or decades and over 100 years of developing community confidence in vaccines. And if you are not able to keep that confidence and there's a problem, it could put us back years and decades. I'm personally very concerned about that. I do want a vaccine. I believe there is going to be a vaccine the next season, not before that. But I hope there are no major challenges with the vaccine, no major side effects. Otherwise, it is going to be a huge, huge problem. I'm just going to show you this. The UK and Europe are the ones who first saw these kids. We were actually seeing babies like children like this early on, but we just did not know exactly what the heck was going on. And we thought it could be Kawasaki or Kawashaki, as we used to call it. But this is, all of you are aware of this. Do I have 1 minute left, sir?
It's almost over. I'm sorry. I'm afraid.
Okay. I'm going to just show you this last slide. This is the most important slide. This was advice that Professor Zafar Haider, late Professor Zafar Haider, used to tell us. This is half of what we know in medicine today is wrong. We just don't know which half. And I've told many of my friends and colleagues that this is what we should know. We don't know exactly how much is what we know is correct, and we may find that what we are doing today is totally wrong tomorrow. So thank you very much. I appreciate your attention.
No, thank you very much for a fantastic talk. And we definitely leave it to the panelists to ask you the questions. We quickly move to the next talk. And the next person is Professor Umar Sadat, who is working in the University of Cambridge, UK. He has been given a title of Humanitarian Professor. He's an academic and clinical lecturer in vascular surgery. It's a very important topic he's going to touch, that how COVID-19 has affected the research and the trials. Obviously, we all know about it. So can you hear Professor Sadat?
Yeah. Can you hear me and can you see my slides?
I can see you, but your slide sharing has not yet been started. Can you start sharing your slides, please? Yes, they are coming up now. I can see your desktop. Can you start slideshow, please? Yeah, they're there. Over to you. Thank you.
Okay. Thank you very much, Waqas, for the kind introduction. I know all of you had a very long day listening to all the facts and figures from different specialties. My job is pretty easy, that I'll give you a very brief overview of what I see has been happening in research. I'll try to make it very light because it's Sunday. I think you spent the whole day listening to all the great lectures already. So how do I see research being affected by COVID-19? I think this is just pure shock and awe. And the reason is that once we went into a lockdown, all the infrastructure and all the resources which were being used for people doing basic science work, like animal models, cell cultures, all of them had to be stopped. And it will take months before all of them can be resumed. Animal models take months to prepare, and so do the cell cultures as well. So it was nothing less than a shock, at least for the basic scientists. Similarly, the clinical research also came to a halt. It has started slowly, but it will take months, if not longer than that, to resume where it was a few months ago. There were a few aspects of research which continue during all of this lockdown period, such as data analytics, and of course, the COVID-related research, which has become more or less like a pandemic in itself as well. Quite a few researchers have been affected quite severely by the suspension of their research grants and the funding that they had. And it will have a lot of implications, which I will talk later on in the presentation. Similarly, the way we interact with our team members, with our groups, it all had to be done via distant learning method. And that has got repercussions, particularly for running the institutes and the businesses which are associated with that. Now, this kind of gives us an idea of how badly research has been affected in UK at least. British Heart Foundation has significantly cut down its budget for the coming year. Cancer Research UK has already confirmed that they're going to cut about £150 million worth of funding. And that means curtains for quite a few research group leaders who are doing phenomenal and foundational research at the moment. If we look at the EU, similar problems there, although the Parliament is trying to stand up to all the proposals of a cut in the budget, and only time will tell if they succeed. How much time will it take for us to return to normality? The expectations are that it will be about 2023 before there would be any sense of normality that resumes within the field of proper academic research. Now, if we look at how the financial world has been benefiting from all of this pandemic, you can see the Goldman Sachs and JP Morgan's making a killing. So on one side, the normal human being, a normal person, a hardworking academic scientist is struggling. And on the other side, you can see the bankers still benefiting while the economy is down the drain. So just putting things in perspective there for you. So I think there's quite an urgent need for government and big pharma to come forward and fund proper scientists who are doing groundbreaking research in all these great institutes all over the world. Here I'll talk more about how I see the quality of research which has been done. And it goes from good to really ugly, but there's more of ugly and less of good, to be honest. What I normally would see is that there should be a need for research, and you always go through a very systematic and logical stepwise approach. There's always some opportunism involved in research, but I think what we have seen is a pure rat race of publishing small reports of 1 or 2 patients, and even Lancet and New England Journal accepting such publications. That is not scientific by any standard whatsoever. This is one of the recent editorials which I really liked, because I was hearing a lot about people using the word cytokine storm as if it was something new, and it was really specific for COVID-19. But in this editorial in JAMA Internal Medicine, they showed that if you look at the interleukin-6 levels, they are like 10 to 100 times higher in ARDS, which means that they're 10 to 100 times lower in COVID-19. But I think we seem to relate cytokine storm as being very specific to COVID-19. Within that article, for your attention, I think I would really recommend that you read this publication in New England Journal of Medicine, in which they pinpoint that it is basically the microthrombi within the airways which make it different, or why the respiratory system fails to cope, rather than the cytokine storm itself. So I think these are those very delicate points which I think we forget, and I think we just get onto a bandwagon of using these very fashionable terms, and media is the one which snowballs this even further. And then we heard that we had a wonder drug, And I was really surprised, when I heard there was a treatment all of a sudden, and then I found it was dexamethasone. Only a few months before that, I had read this paper in Lancet Respiratory Medicine, and it showed that dexamethasone can significantly reduce mechanical ventilation. So is that really a miracle drug? I think ARDS has got far more cytokine storm. So I'm not very convinced with those statements that show up in the media and how it's sold to the public, really raising the expectations and then disappointing them later on. And then we had the hypercycle of hydroxychloroquine. And we know who was blowing that trumpet. And you can see Dr. Fauci really scratching his head and having a bit of a laugh there. And then the same thing happened in France as well, where Macron was also following in the footsteps of President Trump. And we know why that was the case, because there's the US presidential election. And of course, the stock market is something that President Trump loves. So it has to go to the highs for him to have a chance. So every weekend, there will be a news that vaccine is coming next week. And that's what caused most of the stock market to trace up or recover all of its downtrend. And there are quite a few people who benefited from that. So you can see all the shareholders selling at the peak of this. And then because the vaccines are not working at least, and the sample size is really small, you can see they're selling at the peak because they know the future is not as great as they think or as they're projecting it to be. So the market is really overreacting, and so is the public to the vaccine news. And then that's the really ugly side of research. Lancet, New England Journal, everyone aspires to publish in these journals. And you can see, everyone knows what happened there. These guys had to retract their paper, and they retracted in a very nice way that they couldn't access the data. So they apologized for it. Similarly, New England Journal of Medicine had a similar statement published by the same authors. Now, who's responsible for all of this ugliness in academia? Shall we blame these scientists? I wouldn't call them scientists, to be honest. I think scientists is a different category. These are guys who are opportunists, just want to publish something just to make a quick buck, maybe for their CVs or the next promotion, perhaps. I think it's the fault of the editorial board and peer review process. And that's something not new. It's been going on for decades, if not more than a century now, because it's a business. And if we look at other aspects of research which has been done, that's pretty poor as well. So if you look at the number of trials registered for hydroxychloroquine, and this is from the March or April time, and you can read this editorial in BMJ, that only 22% of these studies had sample size of less than 100. I mean, how can you do a trial of 100 patients and then make sense out of that? It's just something that at least I don't understand. And then people take these things very seriously. There was absolute waste and duplication all over these different websites where the clinical trials were being registered. Clinical trials with 30 patients, 40 patients. I really don't know what's the purpose of any of this research. And then there was this pre-printing business, which was coming on this website. Most of these were really misleading. And surprisingly, then we started seeing a trend in which the data dissemination was being done via press releases. It wasn't the first heart transplant which was being done in South Africa, or Dr. DeBakey or Cooley doing some extraordinary work. So I really don't know what sort of data dissemination was being done by the press here. I think that was the dexamethasone I'm talking about. And I think we all know this person here. We know how accurate his models have been. They have just been from almost like 90% away from the goalpost, but he still managed to publish in Nature very recently. So I think the standards for these journals, I'm quite concerned about all of them. So how do I look at all of what has been happening in academia? I think it's basically a Congress of Rough Riders of the world. That's what it is. And I think they're following the principle that you put the garbage in and the garbage comes out. The only thing which has changed is the year, and it's year 2020. So this is a concept which has been there for a long time, that forget about this peer review, blinded peer review, and let it be reviewed by people in the open. And this is something which of course has never been used by different publishing houses, because it's a business, it's a racket. And I don't have enough time to go into details of that. But if anyone is interested in reading more about it, they should watch a documentary on Aaron Swartz, the guy who was in MIT and did try to take on JSTOR. And these are a few pure scientists who, when they had something groundbreaking or what was labeled as the proof of the century, they've just put their work on an open depository, because they don't believe in journals like Nature, New England Journal, Science, Lancet. And these are the people who even reject the Nobel Prizes of Mathematics, or Fields Medal, what it's called. It wasn't only Gregory Perelman, but it was also Einstein, who never liked the peer review process because his first paper got rejected. And that was the only paper that was anonymously peer reviewed. Rest of his 3 or 4 papers in the year, which was the miracle year for him, they were all reviewed by Max Planck. And they just went to the editorial office and he got accepted. Can you imagine all these papers going for a peer review? I'm sure they would have called him delusional because of the theories that he was presenting. So I think good work is still being ignored and overlooked, and the editorial board is significantly responsible for all of that. So what is waiting for us in coming months and years? I think there's a lot of difficulty coming ahead for pure academics because of the funding squeeze I talked about. I think it's very important that we do responsible research reporting. If you have 20, 25 patients, please don't report it. Collaborate with all the people in your area or in your country. Set up a consortium and do some pooled publication rather than just publishing 15, 20 patients. Unless it's a very rare disorder, you're reporting. But if you can collaborate, at least have a decent enough sample size. I think the regulation of data which is being published is very, very important. And I think that's where the universities and other regulatory bodies have let us down significantly. The greed for quick publications, I think we all have been guilty of that, particularly when we start off our careers and try to go up the ladder. But most of these publications are done by professors these days. So I really don't understand why they are so greedy at this level. Then there are these editorial boards which are, I think, they have got a lot of responsibility. And I think the best of research is yet to come, because the serious researchers, they don't publish in 3-4 months. Serious research takes years. And I think that's where I'm very hopeful that good researchers, pure researchers, will publish something groundbreaking in years to come. In the end, I'd like to acknowledge Dr. Tabinda Dugal for sharing her slides with me and for having a few discussions, because I'm a vascular surgeon, so I had to get a bit of a feel of what is happening in medicine, and also to Dr. Tufail for also having a conversation with me. And I'm also very thankful to KEMCA UK for giving me this platform and this opportunity to have a chat with you today.
Thank you very much, Professor Takat. It was a fantastic talk, and we definitely would have some burning questions for you at the end. So we move now on to the next talk, which is a very interesting talk, a bit of a different flavor by Professor Ali Minai, who is an electrical engineer and computer science and working in the computer sciences department, University of Cincinnati, USA. His main research interest includes neural works, complex systems, and networks. So, can you hear me?
I can hear you. Can you hear me?
I can hear you. You can start sharing your slides, please.
Great. You see my slide?
Yes, I think they're coming up. They're not yet there, but they're coming up. I can see your slides now.
Okay, I will go to full screen slideshow.
over to you.
Are you seeing my slideshow?
I think it's taking a bit longer. Yes, the slideshow has started now. You can.
Okay, great. All right, thank you very much. Thank you for KEMCA UK for inviting me. And I'm, as Dr. Waqas pointed out, I'm a little out of the mainstream of the discussion here, but I've been enjoying all your talks. And because I'm not a medical person, I will not say much about the medical side of things. I'll leave that to the experts. My area of research is artificial intelligence and also complex systems. And I will speak from that viewpoint. So it'll be a very general talk. Dr. Athar Saeed, who invited me to this, asked me to keep it very general, so I will try to do that. And I hope it will still be of some interest to people here. So the topic of my talk is the world after COVID-19, are we ready? So I will talk about a few different things. Yeah, for some reason, there's a little bit of a delay in my system here. Okay. All right. So the first thing, as we all know, is that the COVID-19 is a unique event, not only in our experience, but in the experience over many centuries and probably at any point, because really the last pandemic of even comparable scope and comparable size and lethality was the Black Death in the 14th century. And since then, there have been many pandemics, but they've either been slower or have not spread as far or infected fewer people. So, so this is a unique event. And the questions I will look at is, how is it changing the world? How is it likely to change the world? Of course, this is purely speculation and hopefully informed. And what are some of the big questions that this experience has raised and what we should learn from it? So I think this is the key slide in the talk, in the sense that this is where I sort of lay out the main point here, which is how COVID is changing the world. And the way I see it is that the world was already moving. Of course, the world is always moving, like one of the speakers quoted in his talk. But there were certain trends that I think this pandemic is really supercharging. So the US-China divide, the virtualization of everything, especially the virtualization of work and education, the increasing role of smart technology. When I say smart technology, I mean AI, data-related technologies, pattern recognition, and so on, in every aspect of human life. The fusion of technology and biology. So the field I work in, we are actively working on fusing technology and biology all the way from the genetic level to the level of brain implants and artificial limbs and so on. So there's this fusion of technology and biology is already underway, but I think the pandemic and the research that's coming out of it will accelerate that. Also moving to a more data-driven decision-making. So that was obviously already the trend, and that is likely to be accelerated as well. A rise in socioeconomic inequality, I'm afraid, breakdown of trust in government and institutions, and I think we'll see that even more as this proceeds. And finally, increase in surveillance and loss of privacy. I think that will also be increased by this pandemic. But there are also some other trends that were going on, which I think we are finding out that perhaps either we're I think all countries are realizing that being dependent on everyone in the world, or on China perhaps, or some other countries for your manufacturing and your supply chains is not necessarily a good idea. greater human mobility across borders, right? We were on track to make human mobility easier, and we are going to reverse that to some extent, especially because the level of response to the pandemic in different countries will be very different. Greater physical connectivity among people, that relates to the previous one. Universal availability of technology. So that it's going to be invented, smartphone, computers, operating systems of various kinds. It's available to pretty much everyone in the world. Sure, it costs something, but everyone has access to it. But I think I'll talk about that later on. The rapid growth of urbanization in megacities, right? So the last century has seen an inexorable growth in urbanization in megacities. I think now with the role of population density in the pandemic, and also the move to virtual work and education, that trend might start to reverse somewhat. And finally, political democratization and decentralization, more democratic governments, I think might also be reversed to some extent, and I'll also talk more about that later. Okay, so here are some big questions that, and mostly in this talk, I'll talk about questions. I don't get answers. So how will different societies respond to the challenges which have been unmasked by COVID-19? I use the word unmasked advisedly because I think the challenges were already there. It's just that the pandemic has unmasked them, and we can see them more clearly. And those challenges are social challenges, ethical challenges, political challenges, all sorts of challenges. What kinds of governance mechanisms work against a truly global crisis? So is it top-down decision-making or bottom-up decision-making? In this country, where I am in the US, here the attitude of the federal government was, let the states solve the problem. So each state, it's up to each state to solve their problem. Some states have left it to local, to counties and local school boards to solve the problem. The question is, with a global problem like this, is that the best way to do it? Okay, or is centralized top-down decision-making, like we see in some countries like China, is that the better way to do it? And again, I don't have the answer, but the question is going to arise. How conformist or individualist do we have to be? Is individualism in this situation a strength or a weakness? Again, in the US, we see a lot of people who insist on individualism and say, I cannot be forced to wear a mask. It is my right not to wear a mask. Is that a viable thing in the current situation? I think the most important thing is who should be trusted. Ultimately, whether we respond well to this or not is a question of whom we choose to trust. The government, institutions, do we trust our own common sense? Do we put our faith in tradition and faith and religion, God? Do we put our faith in data? Do we put our faith in science? Or some combination of these? So I think how we direct our trust, I think, is going to really determine how well we respond. And we can already see that in some cases like New Zealand, for example, or some European countries, where there was generally more trust in the government, people were more trusting of science and data. And of course, they were smaller countries, but the response turned out to be better because everyone was at least intellectually on the same page. In the US, we see quite the opposite. People are just not on the same page. They don't believe the same things at all. So I think that's going to be a big question. And of course, do we understand why this is happening and how should it change our thinking? So I will go over a few things that I think might be interesting to look at in terms of specific changes. Of course, these are not, this is not a complete list by any means. One is geopolitical realignment. So we might well see an accelerated movement towards a Cold War-like situation between the US and China and then their allies. Again, all this remains to be seen, but that is a possibility. Also, US and China are very economically codependent, right? We borrowed an insane amount of money from them and they hold an insane amount of debt from us. So there's a codependency, and if it starts to unravel, it'll be really interesting to see how that happens. It's never happened before, I think, at least in living memory. the decreased viability of non-alignment for small countries. So small countries which have to go somewhere to get help will then have to start choosing sides. And we already see that in the world quite significantly, even before the COVID pandemic. Again, rethinking of globalization, right? I think this is a really important aspect of this. There's no such thing, there is such a thing as too much connectivity. That's what we are finding out. That just connecting the world completely and making everything dependent on everything else has turned out not to necessarily be a smart decision. And as a complex systems researcher and someone who understands the theory of complex systems, we already knew this. And we know this, for example, from biology, where the dependency between genes is very important. If every gene's function depended on every other gene, the system would be too fragile. And therefore, it does not. There is modularity, and that's been repeatedly shown. There's modularity in everything. But we did not build much modularity into our global systems. So yes, that increased efficiency, but it also increased fragility. As I mentioned, I think there will be some rethinking of democracy in many parts of the world, and by many people, because many democracies, not all, have fared poorly, and many autocratic and technocratic countries have actually done much better. Again, not all, but many. And I think the question will be asked whether we should keep, or in at least some countries, it'll be asked whether they should keep moving towards a more individualistic, sort of American Western style democracy, or whether they should move to a more top-down model where wise people make decisions and everyone else follows. And finally, are we going to have a surveillance industrial complex? Okay, just as we've had the military industrial complex, and I think we already have a surveillance industrial complex. The surveillance is being done mainly by private companies right now, Facebook and Google and so on, but that nexus will keep developing. And I think this is one of the fairly inevitable things that will happen. We can also look at how some things will work in the future. So the future of work, we all appreciate that work is becoming much more virtual. Well, once it's become virtual, will it go back to being, how much will it go back to being in person? Some things have to be in person, but we are discovering that many things we thought had to be in person do not have to be in person. I think it will also increase the already strong trend towards automating processes, using artificial intelligence, and those kinds of things to automate processes and move the human being out of the picture altogether. So I think that will be accelerated by this, which means that there will be even greater divergence between the value of technical work and non-technical work. So technical professionals, engineers, doctors, people like that will obviously still have great value. But non-technical work will become even less valued because that will be automated first. And I think that to the extent that anything pushes us towards that greater automation, and especially intelligent automation, I think that will increase the economic and social inequality in the world. Education, I'm a professor, so I experienced this firsthand. This is a forced global experiment in virtual education, which many of us were resisting for a long time. Now we're all doing it. And in the process, we are discovering some things that are good about it and some things that are bad about it. New models are being discovered. New technology is being developed. And once all this is done, then things will not go back to the way they were. And then that is going to disrupt the educational system all over the place. I'm sure many institutions will not survive. Many institutions will actually thrive. So I think that will be an interesting thing to watch. And on the one hand, this could be a great leveler, right? Virtual education, you can teach someone in Rwanda sitting in the US. So you would think that would make education more available to people who don't have access to it right now. But it also requires resources. And if the resources are not there and education has become virtual, then actually that can increase inequality. And we see that already in the US, where now that schooling is virtual, poor communities where not everyone has a computer and an iPad and all that, they actually are less equal now than they used to be when everyone had to go to school.
Professor Minai, first time check, please. Yeah.
Okay, I'll just hurry up through these. So we can also look at the future technology. The main thing I wanted to point out here is that technology is going to get Chinese technosphere and a Western technosphere. We already see that in some of the debates happening over some of the companies like TikTok. I think we will see more and more of that. And eventually, it will not be the same technology that everyone in the world is using. And that's unfortunate, but I think that will happen. And it'll stress societies all over the world. Innovation has been in some ways supercharged, but also, as the previous talk said, has also been stifled by it. But I think the Overton window for transformative innovation has widened. More things are now possible and considered possible than were considered possible before. So I think that is going to be a big, a positive thing. And finally, I think it's an interesting issue of where people will put their faith. Will faith in science grow? Or will, as if things get really bad, will people turn more and more to their own faiths, and faith in science will diminish because people will see science as having failed? So that's an interesting question as well. So what are the main lessons of the pandemic? I think the one single main lesson, and that's why I use the singular, is that our world has become much more complex than we appreciate. I think this has really unmasked that complexity. And the important thing from our viewpoint, from my viewpoint, is that complexity has certain consequences. Complex systems produce emergent phenomena, right? So the pandemic is an emergent phenomenon. You can't put your finger and say, this is the only reason why it happened. It happened for many reasons, and the way it develops is through an emergent process. And because it's emergent, it's wholly, a lot of things about it are totally unexpected. Okay, in complex systems, there are many other features. Almost all change occurs due to a few atypical events. We see this with economic crashes and so on. We see this with evolution, with punctuated equilibrium. So we see this in all complex systems, that most things don't matter, a few things matter a lot. And this pandemic, for example, is one of those few things. The events which which cause most of the change are always going to be atypical. So by focusing on the typical and the average, we actually are not focusing on what's important. We have to focus on the atypical. Unfortunately, we don't have the statistical tools really to do that. And I think that's a big problem. We'll never have enough data to be reasonably certain about anything. We'll have to make decisions while we are extremely uncertain. And you as doctors are obviously used to that. But I'm afraid that lots of policymakers are not as used to it. Connectivity matters down to the smallest details. I won't go much into this, but we know in complex systems that every connection counts, and small differences can make in the outcomes. There's no silver bullet solutions. Too much efficiency may be dangerous. I talked about the organization. Important thing. It's really
Sorry, Professor Minai, your voice is breaking too much, and we can't listen anything from your side. And I think it's the second time check. This time is over already.
Okay. All right. So can you hear me now?
Yes, that's better now. Yeah.
Oh, okay. So I don't know, it must have been some glitch. Okay. So I will stop here. I will just say that scientists and policymakers understand all these things. But unfortunately, but policymakers don't always understand this, and this must change. So I will stop here since I'm out of time. I was on. The question will come up. Thank you very much.
And thank you for sharing your views. There are some out-of-box solutions you have shared. Now I hand it over to our panelists. I hand it over to our chair of this session, Dr. Tabinda Dugal, who is a consultant endocrinologist at Common Hospital, and she's also secretary for KEMCA UK. Along with her, Dr. Adeem Murtaza, who is a general practitioner in West London, and he's quite actively involved in KEMCA UK and other portfolios like CCGs. So over to you, Dr. Tabinda.
Thank you very much. And I know it is the to the graveyard session and a very long day, but I would start off with some questions, if that's okay. There are two panelists who haven't been introduced already by the moderators, and they are Dr. Samia Wasim, who is the KEMCA president, and there is President-elect Professor Muhammad Aslam. They are both from US. Professor Muhammad Aslam is Professor of Psychiatry in Cincinnati, and Dr. Samia Wasim is, as I said, KEMCA president, as well as a family physician in Virginia. So may I start with asking question, first one to Tufail, if that's okay?
Yeah, absolutely.
So I've had some questions from the audience, and they've said they're asking about rationalizing radiology in this time, because as we know that, you know, in COVID times, radiology has also been impacted upon. So did you have any ideas about how to rationalize using radiology to diagnose cancer in this time?
I think this is an excellent question. One thing I can tell you, from our experience of radiologists, really, they are an excellent bunch of people, and they have not been that busy during COVID-19 season at all. In the UK practice, we don't do CT scans routinely on these patients. So in our unit, we had 3 CT scans, and 1 CT scan we just reserved for COVID positive patients, and the other 2 scanners were working very well. So really, the radiologists in our department were waiting and to accept patients, and I don't see any problems in that. Yes, we had problem to perform, for example, CT guided lung biopsies or interventional procedures. You have to wear proper PPE and to perform these procedures. And also, I mean, we have put loads of measures into it. For example, whenever patients come for CT, you are asked some questions about whether you are COVID positive or not. For CT guided biopsies, we always do COVID swab test. So lots of things have been done. I don't believe in that radiology is that a problem as long as you use them wisely.
So I think that probably the best thing is starting from the GPs, just disseminating the information that the CTs are working as is. So I don't know whether you've done that. Obviously you've done that, and receiving referrals from them and then going ahead and doing that. So I think Dr. Adeem has also got some.
Yes, this is a question. This was a question from Talha Munir, and the second question, which is again to Dr. Tufail. But before that, I must say that working in a primary care setup, there is a backlog and there is a slight hindrance from the radiology point of view. Although our senior and secondary care, tertiary care colleagues have no problems getting access to radiology, but majority of the so-called non-urgent work has been rejected by the radiology, and this has actually resulted in the couple of incidents where the early diagnosis was missed. The second question, Dr. Tufail, to you is from Dr. Mahreen Chowdhury. He is also a general practitioner who suggested that because all the general practice appointments currently and in future, probably majority of them will be remotely or via video consultation. So are we missing any, is there any secondary colleagues who are preparing templates for different, especially the pulmonological oncology, so that we can ask the questions to the patients over the telephone or video consultation in order to detect if there are any red flag signs?
I think these are 2 excellent questions, and it all depends upon how the primary and secondary care come together. I think the need of them coming together is very, very important. Integrated medicine is the future for UK. I can give you an example of my unit, how we manage our lung cancer patient. Only thing we want you to suspect cancer and send the patient for chest X-ray. And in my optimal lung cancer pathway, for which we have been shortlisted by BMA awards nationally, that you only need to send them for chest X-ray. No, chest X-ray, patients come for chest X-ray is reported. If there is any suspicion of lung cancer on the chest X-ray, our department will automatically book that patient for CT scan. Consultant will have a look, consultant chest physician and consultant radiologist will have a look on the CT scan. If there is a lung cancer, we will take over the patient altogether. And if patient does not have cancer, we will call the patient and tell them, yes, there's no cancer. So it all depends upon how you organize your services. And optimal lung cancer pathway has been implemented in UK over the last 2-3 years. And I know the practices vary, but by collaborative working between different departments, I think you can do wonders. And you have to, as I said in my talk, you have to find new innovative ways of working. It's not going to be an easy time. There will be lots of backlog. There will be lots of advanced stage cancer patients sitting there. We have to collaborate more than before between primary and secondary care. And coming to that second question again, I mean, we had run the campaign every year that, and we had put billboards everywhere in the UK that if you have got cough which is lasting more than 3 weeks, please go and see your GP. It could be cancer. But COVID has ruined that, basically. So I think we need to come back to that. We have to be mindful. I know face-to-face appointments are not happening, but there are some clues which can help you. For example, COVID symptoms, usually most of the patients, cough, shortness of breath, fever, they will not last more than 4 weeks. In most of the patients, I will say. If they are lasting more than 4 weeks, I mean, I think we need to question cancer here. And also, there are some symptomatology clues. For example, if someone is having hemoptysis and chest pain, it's more cancer rather than COVID, because hemoptysis is not very common in COVID. Similarly, loss of taste, loss of smell is more common in COVID. It is not common in lung cancer. And it's just the, for example, you look at the finger clubbing, for example, quite a common sign for lung cancer. So we have to be mindful of all these things. So I will encourage all the primary care physicians to collaborate with their secondary care physicians and have a low threshold to see these patients. In my pathway, I have informed all our GPs in our areas, please have a low threshold. If patient doesn't have cancer, fine. No problem at all. But we do want to go back to that and picking that patients early in their disease. Thank you.
Okay, next question for Professor Afzal Javed is from one of the audience, and they've said that there were loads of questionnaires floating around during this COVID-19 epidemic about assessing the effect of the pandemic on the patient. So would you like to recommend a particular questionnaire? And the next question is from my side is that I know you highlighted the challenges of practicing psychiatry in these times, but a lot of places like in Canada and rest of North America, they have taken to telepsychiatry. So I don't know how that is faring here in the UK, and if not, why? And lastly, another question that I had, which is something close to my heart, is that a lot of patients with psychiatric disorders have got comorbidities like diabetes, which may sometimes be induced by the medications they are taking. So they are under a double whammy at this time where they don't get access to services, medical nor psychiatry services. Is there anything in place for these people? Because they will fare very badly if they get COVID-19. So over to you, Professor Javed, please.
Well, thank you very much for these questions. Regarding the questionnaire, I know that there are many universities, many researchers who are using this opportunity to know about psychiatric morbidity among the general population. And it could be the best way to find out that which university or which center is near to you, because what is the purpose of these surveys? The purpose should be to make awareness, not only for our clinician colleagues, but more importantly for the policy makers, that this is an illness which doesn't need only ventilators or other equipments, but this is something which needs to be seen in a wider perspective. So I see a positive side of this data collection, that at least that is raising the profile of an important part of the comorbidity, which needs to be addressed in a more scientific way and in a more clinical way. Regarding your other question about telepsychiatry, this is a sort of a new phase of psychiatry which is going to come, especially after COVID-19. And I can tell you that in UK, but more importantly, I have got some personal involvement with our Pakistan Psychiatric Society in Pakistan. They are doing a lot of work in terms of using these digitalization and the modern technology, not only for seeing patients, advising patients, but interestingly, our faculty at the College of Physicians and Surgeons is using telepsychiatry for the telepsychiatric education in a very big way. And while we were listening to the last speaker, the world after COVID-19, I think this bedside teaching, clinical teaching will actually be added and supplemented by a lot many innovations in terms of the telepsychiatry. Your third question about the comorbidity or the issues relating to medically unwell people or having people medical problems and how could we sort of help them. I think that's a sort of another important aspect that COVID-19 has emphasized. I mean, generally speaking, if you look at someone who is in his 40s or 50s, he or she may be taking treatment just for one illness. But if you go in 50s, in 60s, in 70s, the number of comorbidities increase. And probably that is a lesson which need to learn, that how are we training our future doctors in terms of dealing with the comorbidities. And you are absolutely right that it is very difficult that if somebody is diabetic and some sort of psychological symptoms overlap, and in addition to that, some issues relating to the COVID-19 emerge, how should we really tackle the situation? So probably this is something which we really need to check. And more importantly, I try to emphasize, but because of the time limit, we couldn't discuss it further. There are a number of issues, especially in terms of management, use of the drugs which we are using in COVID-19, some of the side effects of psychiatric treatment. So all these needs a sort of a revisiting by our colleagues, by our physician colleagues, by our psychiatrist colleagues. But we hope that this experience will certainly enrich our clinical expertise, our academic background, and more importantly, our pursuit for further education and knowledge.
Thank you very much.
Sorry.
So it seems that we will have to really rewrite the book altogether, isn't it? Because after this, there are so many changes that are going to happen, and it will take years for everything to implement. So in the meantime, I think we have to stick with best practice and carry on what is best for our patients.
I think if you may allow me, this is one of the very, very wonderful idea that KEMCA UK, in addition, in collaboration with KEMCANA, with KEMC University, I think we should really try to produce something in paper, that what are the advances in different modalities and different specialities. And thank you for this excellent suggestion.
Over to you, Adeem.
Thank you. Whilst we are on psychiatry, can I ask Professor Aslam Saab's opinion? One thing which I must admit, that Professor Aslam smile has not changed since the college days. Whenever I see him in APNA meetings, always smiling, even though he has been a psychiatrist for so many years. Sir, the issue is psychological impact of the disease, COVID, on general public. It's a broad question, but I'm sure that you will sum this knowledge up with us. Thank you.
Thank you, Adeem. It's a great honor and pleasure to be part of this comprehensive webinar. I want to congratulate KEMCA UK for holding this excellent webinar, like I said. And again, I want to thank you, all of you, and good to see some old friend like you, Adeem. And I want to thank you, Dr. Tabinda Dugal, for introducing me, and Dr. Tufail, including me on the panel. I appreciate it. I think I want to just say that what has been said by Dr. Afzal Javed, again, it's an honor, Dr. Afzal Javed, to be part of the panel and to see you personally on the video. I have heard your name again, and I think you were at KMU last year, and I heard that you did a great job and educating about the psychiatric care, which is, I think, very near and dear to me. Once I came to the United States, again, I have no clue that I want to become a psychiatrist, by the way, because the societal stigma we carry in our societies. But anyway, coming back to the question, I think, Adeem, like you said, it's a broad question, but again, in the survey which were done in March 2020, which showed that 40% of the people in general, they were feeling anxious and about contracting the COVID virus or even dying from it because if something bad happened to them or the contact. And 19% reported they have sleep problems. About 8 to 10% even start consuming more alcohol. People who are using alcohol, or people who are not using alcohol, they start because of the lockdown, staying home, they start using alcohol. And as a result, once you have this alcohol or other drug problem, there was a lot of increase in domestic violence, which is another issue I think we should pay attention to, no matter what our specialties is, because mental health issue matters. And it's everybody's responsibility that we should screen patients, not only for depression and anxiety, but some of the other violence may happen as due to the lockdown and other issues. There are some increase in interpersonal conflicts, and these are the things we have seen more and more since the COVID pandemic has happened.
And so another question for Dr. Aslam is that I know you're an old age psychiatrist, and I think it is a problem that is less recognized in Pakistan, the isolation of the elderly, even while they're living within family. So I think this is something we need to work on as well. How has it impacted on your practice in the US?
Well, yeah, it has. Again, I think all the things which have been said that because of the pandemic, I treat, like you were saying, as a double whammy because the patient have already pre-existing condition, medical condition, and then on top of that, they have psychiatric condition. And then we are asking them to stay socially isolated, and they are staying in their homes. Or some of the patients who are living in an old age home, or nursing home, we call them, they are not allowed to have any visitor. And that had tremendously affected their mental health conditions. And I see more and more. And then again, because we have to change our practice as a result, and I've been doing telepsychiatry since March of this year. I was the first one in my hospital, went to the leadership of my hospital, and I wrote kind of email to them that I see risky population because most of them, they come with their families, they cannot drive, they have been brought in by their children or spouses, and they are like 2-3 people in my room, and I don't like to be exposed or don't want to be exposed from them. And the hospital administration was very flexible about that. And I've been working from home, doing video visits mostly and some phone visits. That I will say.
Thank you, Aslam Saab. My next questions, 2 questions which are sent by Professor Saira Afzal from Pakistan. All questions are very intelligent questions, but these 2 are very specific. One is to Professor Umar Sadat, and the other is to Professor Mobeen Rathore. So I will go one by one. The first question is to Professor Sadat. Sir, the question is that is there any research going on for thromboembolism and the vascular endothelial damage, especially in the COVID? And the question to Professor Rathore is that are we testing the neonates born to the infected mothers with COVID? Thank you. First, Professor Umar Sadat, please.
Yeah, so as far as research into microthrombi generation within the pulmonary system is concerned, I'm not an expert, I'm not a pulmonologist in that field. I think Dr. Tufail would be in a better position to comment about the latest developments. And perhaps if there's a hematologist here, he would be able to perhaps comment. But I can only talk about a couple of review articles that I've seen in Lancet Rheumatology from Leeds. I think it was Professor McGonigal, I think. He published end of May or beginning of June, in which he talks about something what we call macrophage activation syndrome-like picture, which causes the endothelialitis. He has done some work, I think it got published in Annals of Immunology, and he labels it as immunothrombosis. But that's the extent of my my information on this topic. So I think I'll leave it for Tufail, or if some hematology is there as well, I think they can talk in a bit more detail on this topic.
Would you like me
Professor
to
Rathore?
or Professor? Yeah.
Thank you so much. I think Sarah's question is a very important one. I think we are not routinely testing newborns, or in fact, in Florida, many places we're not testing routinely mothers. But if there is a mother who's positive, we are separating the babies. I showed you several studies which show no evidence of perinatal transmission of SARS-CoV-2 to the newborn. So yes, there are places that are testing newborns at after 24 hours of age, and really the data does not support that. And with the shortage of testing, we have chosen as a stewardship of testing not to routinely test the newborns, but really separate the newborns from the mothers. And if they are symptomatic and stay away for 10 days, we assume that they are not infected. Just to answer what Dr. Sadat was saying, there are actually studies, and I'm aware of at least a couple, where they are looking at the hypercoagulable status and nature of the COVID-19 disease. And we are actually, not me, but our colleagues are participating. And these are not very large studies that I understand, but there are some studies going on. And this is also an area of major interest for hypercoagulability, because as we have learned, it's not really the respiratory parts of the disease that kills, it's the hypercoagulability. And but that's one of the reasons I believe our death rates are down, because we are better at managing these patients. So I think Tufail probably has something that he could add.
No, I agree with you, really. I mean, it is something unknown at the moment. As we mentioned before, there is an evidence of heparin resistance in these patients, endothelial injury. So it's a bit early days at the moment before we can create some concrete conclusions.
Thank you.
So
Tabinda.
Yeah, I'm going to ask this question to Professor Cheema. It's just a general question, and I think it will help us all in kind of managing our workload once things go back to relative normality. So how do you suggest that you will manage your cancer or scope backlog once this settles in September?
Yeah, I think
a very open-ended question, but
it is indeed. But I think it's to do with restructuring your resources. For example, as this pandemic took off, the endoscopic diagnostic pathway completely came to a standstill. So it is, like I mentioned in my talk, there are about 200,000 patients who missed their diagnostic scopes during the last 4 months with suspected symptoms. So you got to sort of cater for those. Then secondly, you probably would pick some of that workload filtering through unplanned emergency admission. So they would be presenting with potential bowel obstruction, and the whole idea of sort of having a primary health care directing these patients for diagnostic was to avoid that situation. But inevitably, these patients would come through emergency pathway. Coupled with this, what has happened is, as you probably know, here in NHS, most of these diagnostic scope work was outsourced to a number of these independent treatment centers. And a lot of those diagnostics were done through there. And that has come to a complete halt since mid-March. And they are just beginning to sort of open up their resources again. So expansion of what you call infrastructure or capacity is an issue which the NHS has to address. Subletting some of these diagnostic away from the main NHS body of work is going to be another issue which they have to address. And then perhaps incorporating more workforce to do all of that diagnostic workup effectively is going to be another challenge for us. So as the floodgates open, as you expect, it's not going to open on, let's say, 2nd of September. You would start to see what you call a lag time. When in 2-3 months time, you start seeing more emergencies, unplanned bowel obstruction within my specialty, for example, or people who at the moment have been sent away for having chemoradiotherapy, so by time effective, we would be finishing their treatment and they'll be coming back for the definitive treatment. There would be a sort of effectively a capacity issue as well. So I see this as an ongoing evolving problem. I also see, people trust management, CEO offices trying to have what you call logical thinking around the problem, and some national guidelines, which arguably is driven by science, being imposed on us effectively. I think this is what we have to cope with. This is never going to be a normal. It's going to be a new normal we all would learn to live with.
Thank you very much. Thank you. And my question to Mr. Minai, Ali Minai, is from one of the panelists, one of the participants, Saira Afzal, and she was asking whether you could tell us more about the surveillance industrial complex and how it will work in disease prevention, please.
Well, the disease, because of all the tracing and the information about outbreaks and so on, of course, we need a lot of surveillance, right? We need lots of information. So the technologies for that are being developed. But a lot of those technologies already existed and they were being used by, for example, Google or Facebook or companies to sell advertising. And now those technologies are being repurposed for epidemiology, which is great. But the problem is that once this sort of thing comes out, this genie comes out of the bottle, it is not going to go back in, right? So, we were already very concerned about the use of AI, for example, face recognition and so on in law enforcement and things like that. The kinds of technologies that are being developed now in terms of keeping track of people and what they do and where they go and what they like, I think that is going to be one of the biggest areas of technology in the coming decades. And at the same time, how to not get caught. So cybersecurity obviously already has that aspect, but that is also going to grow much more. So just as we have an arms industry, we are now developing a cybersecurity industry. We are also developing a monitoring industry, a surveillance industry, and these things will keep growing as more and more of our lives are lived on the internet and in virtual domains. So it's much easier to track what I'm saying or what I think now that I'm on Zoom day and night, right? So I think that's going to provide enormous amounts of data for surveillance of what people think and how, what people will say. And that's primary.
Okay, thanks. And so I think before we wrap up, I have a question for Samia. And I was going to ask you, how is primary care dealing with this challenge? And are there policies that are made by national government, or are they being made locally, or is every, for example, locality making its own rules, or are they being imposed on them?
Thank you very much. Can you see me on the screen? Because I really don't.
Yeah.
I'm just, as I'm a GP over here, and we, as Dr. Tufail said, that the main concern for us was really that the normal primary care that we suggest was jeopardized or put on back burners. And we are working at very local level for our private, for our patients. We are just telling them to come back to do their primary care tests, which are required by guidelines, because people are dying from heart attacks. People are worsening of congestive heart failure is being seen in private practice and in hospitalization. And now we are just giving them local guidelines from ourselves and also from expert that, we should go back to our primary testing, whether it's primary lab work, colonoscopy, or PAP or mammograms, because now there are guidelines at places For example, in colonoscopy, they do take your history, they take your temperature, and they also do a fast COVID test. So this is our main thing. Yes, there are no special guidelines by the state. As for schooling, I tell you, in Virginia, half of Fairfax County where I live, they have decided to go all on virtual, not hybrid. But there are other parts of the state where they are doing hybrid. So my most stress for my patient is really to go back on screening. Because COVID might go and other things may linger on, you know. That was it. Thank you. Thank you very much, Dr. Tufail and Dr. Dugal. I just, you know, thank you very much for showing this brotherly love between KEMCA UK and KEMCANA US. And I appreciate it. It's a wonderful webinar. Wonderful, wonderful.
Yeah, it will grow ever so stronger in future time to come. Let me just, with permission of Tabinda, just quickly, Professor Amjad would like to ask a quick question. When I say quick, means quick.
Yeah, no.
To Umar Sadat and Ali Minai.
I probably would have met Umar's question because I know the answer partially. It was to do with funding for non-COVID research that we have to sort of do, but I know the answer. But it's a shame that I missed some of the talk from Ali because I was very interested in that. I'm interested in robotics and pattern recognition and automation, and we are doing some research with Dresden Uni. The question I have is very simple. This pandemic obviously have taught us this is going to be a new way of learning. So with AI and pattern recognition, particularly with diagnostic, I have believed for a number of years the diagnostics from the healthcare would be the first to disappear to machines. So has this pandemic fast forwarded it? And how far realistically we are before the pathology patterns, for example, radiology patterns and primary healthcare disappear to machines?
Should I answer or?
This is for you.
Okay, all right. Yeah, so I think, I mean, from my own experience, from what I see from colleagues and so on, I think that actually the pandemic has really increased the work in this area. So many people I know who were doing research on AI in other areas have completely diverted their research towards this. So whole labs have turned around. It's like, you know, in World War II, Chrysler and Ford started making tanks. So anyone who was working on anything is now working on COVID. Now, as Dr. Sadat pointed out, not all of the research that will come out of that will be top-class research, but some of it will be. And new methods are being developed, and I think that's going to have a huge impact. So that's number one, and a lot of funding also for that. The second thing is that, as I also mentioned briefly, I think things that we used to consider not feasible are now being considered feasible. Right. So I mean, I see that in education, and I don't know exactly how the medical profession respond, but at least from the doctors I talk to, I think they're much more open to using these kind of techniques in diagnostics. And I would say a few years ago they were not very open to this. I've worked with a lot of physicians in my research, and you know there was always this feeling that the doctor knows so much more than any machine can, and therefore we'll never get to that. And I think this pandemic, among other things, the development of technology also is showing that, well, you know, maybe there's some things for which we need the doctor, but there are also many things which can be done pretty well by machines. I'm actually, even though I work in AI, I'm an AI skeptic in the sense that I think that the hype is far ahead of the reality. But I think in areas like this, I think it will become more and more important and more accepted. Whether that's a good thing or a bad thing, I don't have any judgment on that.
If I could have an opportunity to make a couple of comments, if that's okay for the host.
Yes.
Two things.
Which moderator?
I'll tell you, for our research program, we run a large research, obviously it's on HIV, that's my area of research. But as somebody said, there's been a shift. We are now part of the COVID-19 prevention network, we're doing studies. So what has happened is the National Institute of Health has taken our network and has shifted over to study COVID-19 as it should be. Not that the HIV research is not important, but that's really stalled and stopped. But the COVID-19 research is, I mean, it's happening so fast and furious that in my 30 years of doing research with the NIH, my mind, I mean, I was telling my team that I can't get my arms around it. It's so fast and furious right now. So I think it's called, they actually call it warp speed is the name of the initiative for research. So I think that's something that's going on. I would just say, I mean, just one thing. I remember this statement I heard many years ago, before the time of internet and all of that, that 1,000 computers can do the work of one person. But no, one computer can do the work of 1,000 persons, but 1,000 computers cannot do the work of one smart person. So I think we need to keep that in perspective.
Sure, absolutely. We can't even do the computers cannot even do the work of a rat right now.
Over to Tabinda for concluding remarks.
A couple of comments, actually.
Yeah, just a very quick comment. So I can tell from my perspective that I'm involved in a pharmacogenetic study in depression outcome to see which antidepressant may fit better for you guys. And we were put on a hold by our research national office as the pandemic started. But then we got together, we did some brainstorming, and as a result, we have started doing virtual informed consent, which is kind of a new thing, which never I thought it will happen. But now we mail the informed consent to the patients. We go over on the phone and they read line by line. And if they have questions and they sign it and send it back to us. And that's how we document that. And I think it's not, like in the past, some speaker has said that there are new models are being discovered, and it probably will be more discoveries coming. And as far as my practice is concerned, I work for also the federal government VA health system. They have said that 70% of the practice will stay virtually, no matter whether this pandemic is over.
Thank you very much. I think we are now touching the timeline.
So it is now upon me to close this marathon webinar. And, you know, we all live in this time of pandemic, and it's an unseen enemy for all of us. So it's unprecedented time with unknown challenges and new challenges. So it is important, and it's imperative upon us that we continue to share our experiences and help each other in progressing how to combat this virus at various levels. So this webinar was an effort to do exactly this, and I hope you have enjoyed it as much as I have. So, you know, I remembered a few lines from Tennyson, and I will read them out. They about 4 or 5 couplets. So, though much is taken, much abides, and though we are not now that strength which in olden days moved heaven and earth, which we are, one equal temper of heroic hearts made weak by time and fate, strong in will to strive, to seek, to find, and not to yield. So I think that our human spirit remains, and no matter how much we are struggling with AI, computers, surveillance, and everything, we still have our hearts and the strive that we hold in our hearts. So I think I'd like to thank all the speakers, the time that they took out on Sunday, and all the participants and I hope that they have taken home at least some messages to benefit their patient care. And a big thank you to all the moderators, Waqas, Asif, Abdullah, and of course, Tufail in organizing, coordinating all the speakers and running the show. And so all to the participants, please do the feedback forms, because then you can get the CPD. And please enjoy the rest of your Sunday. Stay safe and stay social distancing and all the things that you got to do. So thank you very much all.